In this lecture, we will discuss sinus pause and sinus arrest, as well as how they would appear on the EKG. The sinus node is made up of two main groups of cells, okay? The pacemaking cells, which are also called the P cells, and the transitional cells, or the T cells. The pacemaking cells make up the central core of the sinus node and are responsible for producing the sinus impulses, whereas the transitional cells, or those T cells, make up the outer layer of the sinus node and are responsible for transmitting the sinus impulses out into the right atrium. Okay, so again, let's look here. We have imagine our sinus node here. Let's first go through our conduction system. All right, this is our sinus node here in our upper right atrium, okay, near our superior vena cava. Then we have our internodal pathways coming to our AV node, okay. Remember, to the left here, we have our Bachmann bundle. And then from our AV node, which sits here, we have our His bundle. Okay, that splits off into the right bundle branch, and then we have our left bundle branch. The left bundle branch subdivides into the left anterior fascicle and the left posterior fascicle. Remember that left anterior fascicle innervates the anterior and superior portions of the left ventricle, while the left posterior fascicle innervates the inferior and posterior aspects of the left ventricle. So both after these fascicles and the right bundle branch innervate, and they go to transmit their impulses to the ventricular Purkinje fibers that then innervate the myocardial cells, okay? And then we have the impulse transmitting by that means. So what we're talking about here is our issues here with the sinus node, okay? And remember, the sinus node, if you look here in the middle, we have these P cells that are called the pacemaking cells, and this outer layer, this T cell, is the transmitting cells. Remember, the impulse starts here, and then from that, the impulse then goes out to these transmitting cells that will depolarize that right atrium, okay? Now with sinus pause or sinus arrest, the problem is with these pacemaking cells. The P cells may fail to produce an actual impulse. And if the problem was with the transitional cells, then we would be talking about something like sinoatrial exit block, okay? So what we're talking about here is with these P cells, okay? The problems here is with the P cells, the ones that start and initiate the impulse, but they're not doing it. So if you look here, sinus pacemaking or P cells are failing to produce any impulse, okay? So we just have no impulse that's coming from our sinus node here, all right? So if you imagine no impulse coming from this area, that means nothing is gonna depolarize and transmit through the rest of our conduction system, okay? So let's go through our chart here. We said that the sinus P cells are failing to produce any impulse, okay? So no impulse is coming. Now I want you to just be aware of this. There's something, this cutoff between pause and arrest, and why we do them together is it's really just a matter of how long to differentiate between them, okay? They're pretty much the same thing, sinus pause or sinus arrest. It's just how long does one last. Now there's no real cutoff, but based on some research, I found that it's really between 2 to 3 seconds is the cutoffs that have, some suggest, okay? Meaning if you have a beat, okay, and nothing occurring for, say, 1 second, all right, that would be sinus pause. But imagine if this was actually 5 seconds, okay, or just persisted even longer, we would call that sinus arrest, okay? So again, less than going this way would be sinus pause. If it's greater, sinus arrest. I just want you to be aware of that, okay? Now what we'll see is these intervals between these are not multiples of the normal P to P interval, okay? And this will be different when we talk about sinoatrial exit block, okay? The exit block has a problem with the T cells. Now some causes of sinus pause and arrest are sick sinus syndrome, so a problem here with the sinus node, as you may expect, an increase in vagal tone, which can be seen in athletes, or increase in vagal stimulation and pain or surgery, inferior MI that maybe affects that area, myocarditis, so infection of the myocardium, medications such as beta blockers, calcium channel blockers, digoxin, amiodarone, so all these can affect that and potentially cause sinus pause or arrest. Now when we talk about the regularity of this rhythm, it's irregular, okay? So if you look here, notice we have our P wave here. This is where the next P wave should be coming, but it's not there. And the one that follows that, if we were to follow this sequence, would fall at this point, okay? But we'll see that it's actually falling a little later at this point, all right? And that's what we mean where the intervals are not a multiple, okay? So our P wave to P interval would be this, and then if it were to continue to follow this, it would fall there, okay? So again, P wave fires, then we have our normal conduction, and then nothing comes afterwards, okay? So no impulse is coming from those pacemaking cells. And because of that, the rhythm is not actually regular, okay? We already see a dropped beat, okay? We'll see there's a drop beat, and the whole rhythm is irregular, okay? So again, the rate will vary based on what is the underlying rhythm, okay? Or what's the underlying rate of whatever is going on when they're actually conducting through. Okay, so the rate varies. We have an irregular rhythm, and the P waves, if they are present, okay, they'll be present except in the areas of sinus arrest. So again, look, there's a P wave here, there's a P wave here. The P waves are still there, but where they're occurring, notice there's no P wave there. Okay, so the P waves are present except where you have this period of arrest. Okay, so we would call this probably a sinus pause because it's not lasting as long as an arrest. In terms of the P wave to QRS ratio, okay, so pretty much everything outside of that gap is the same. So you have a P wave to QRS will be 1:1. P wave to QRS 1:1, except in this area where there's nothing happening, okay? And remember, why is nothing happening there? Well, again, the problem here is with our P cells, okay? So our P cells are the ones that initiate the impulse. So if we have no impulse coming through them, okay, nothing's happening. There's no impulse, there's no P wave that can be present, and nothing will happen afterwards, okay? In terms of the PR interval, okay, the PR interval representing mostly AV nodal conduction. If you imagine this is our T wave, QRS complex, and P wave. Just to review, here's our P wave, PR interval from the beginning of the P wave to the beginning of our QRS complex is normal when we see it, okay? In other words, here's one complex. This will be a normal PR interval, okay? Wherever you see these normal P waves that actually get through, and when the sinus node actually fires, you will have a normal interval. Okay, so AV nodal conduction is normal. In terms of the QRS interval, everything will be normal. Okay, the issue is only up here with our sinus node. Everything below there is happening normally, so it should be between 70 and 110 milliseconds. In terms of grouping, there's no grouping. All right, but there is in fact a drop beat. Okay, we saw that there's no beat occurring because the sinus node or these P cells, these pacemaking cells, are failing to produce an impulse. Okay, so where there's no P wave, there's no atrial depolarization, and there's no AV nodal conduction, and no ventricular depolarization, and so forth can occur. All right. So hopefully that's starting to make sense. Now let's take a look at this time interval that we've been mentioning. Okay, we mentioned it earlier where we said that the time interval is not a multiple of the normal P to P interval. So if you imagine here's our P to P, okay, meaning this is our normal P to P interval, okay, and if we were to continue that, it would go here. But notice we have our P wave that should occur here, and if the beat that follows it should occur here, although it doesn't, all right? And because of that, you notice that it's occurring actually afterwards, okay? Here's our new P to P interval, okay, occurring at that point. So why is that happening? Well, imagine the P wave cells are actually firing, they're working, so everything's fine, and then they stop working, okay? They stopped working here, they continue stop working, they stop working, and then eventually right here, they decide to fire, okay, and get through. So that's the issue going on. Just one thing to note is that they are not a multiple of that normal P to P interval, which will be different in some forms of sinoatrial exit block. Okay, so let's briefly review what we discussed before we end. So sinus pause or sinus arrest is a result in failure of the pacemaking or P cells to produce an impulse. Okay, so no impulse can come from them, and because of that, nothing else gets through. In terms of the sinus pause versus arrest, remember there's that 2 to 3 second cutoff that some have proposed. Again, no generally set cutoff, but that's what you can use. Okay, so if you imagine you have from here to here, that's certainly less than 2 to 3 seconds, okay? So this would be sinus pause, all right? Or even very close to a sinus arrest, okay? If you're probably to count that out, it might be about 2 seconds, okay? So depending on who you talk to, they may call it sinus pause or arrest. But we do these together because, you know, there's really no really defined criteria for that cutoff point, okay? So in terms of the time intervals, we saw how the P to P intervals, right? The only thing that occurred once these P waves started to fire is when we saw that next one coming, okay? So they're not a multiple, all right? So again, when we talk about the multiples, we would, if there was a multiple, we would see the next P wave occurring here, and if not there, it would occur there, okay? but we don't see that. We talked about these bunch of causes, and that pretty much are the things that affect this sinus node, okay? Including some surgery. Some athletes may have this sinus syndrome in older adults, inferior MI, infection of the heart, and a bunch of all these medications can cause them, okay? Remember, this is an irregular rhythm because we have these drop beats that are occurring, making it irregular. The rate will vary based on whatever the underlying rhythm is, okay? And whatever it's firing at. So you can look at that. But it will vary in terms of, and remember, when we look at irregular rates and what the rates are, you have to count the complexes going across a normal standard 12 lead EKG and multiply that by 6, okay? And it may vary based on what portion you get of the actual thing for sinus pause or arrest. In terms of the P waves, remember, they're going to be present, but only outside of where that sinus pause or arrest. So imagine this area is where our sinus pause or arrest. There's no P waves there, but everything else, we see these normal P waves. There will be that 1-to-1 ratio outside that area, right? The P wave to QRS complex are still the same. Nothing's affected. The only thing is we just can't get an impulse from those P cells to fire. The intervals, the PR and the QRS intervals will be normal. AV nodal conduction, ventricular conduction, all that area is still happening normally, okay? In terms of the grouping, there will be no grouping, but again, we do have a drop beat because remember, these P cells are not firing, so if there's no P cells, we can't get any conduction to the ventricles to form any QRS or repolarization wave with the T wave of the ventricles, okay? So hopefully this is starting to make sense. Well, that's the end of this lecture. We discussed sinus pause and sinus arrest, as well as how they would normally appear on the EKG. I hope you learned something.